Okay, good morning, everyone. This was supposed to be a 10-minute talk at the end, so I have prepared it brief. So, cervical lymph node. What is the role of the pathologist in the evaluation of cervical lymph node? So, I'll be starting from what are the types of specimen that we receive, and then we shall go accordingly. Yes. So these are the specimen types that we usually receive. We can have FNEC, fine needle aspiration cytology, a core biopsy, a whole node excision biopsy, or an incision biopsy of a lymph nodal mass. We have in the main specimen, we have the neck lymph node dissections, which can either be sent for frozen sections or for final HPR. Now, FNAC is usually done when we require a quick diagnosis, usually to rule out metastasis and nodal or a soft tissue recurrence in head and neck context. Many a times for ruling out benign pathologies, some cysts, abscesses, COGS, where we can obtain the material for microbiology evaluation. It's the FNAC is the primary modality in the thyroid and the salivary gland evaluation. We should not do FNAC when we are suspecting lymphoma or the clinical picture is going towards a lymphoma or an unknown primary, because we need to find out the origin of the tumor. So for that, we might require IHCs, which are not possible on the FNAC slides in the usual way. The second modality is a core biopsy. Core biopsy is in all good modality for most of the pathologies. It ensures the excellent fixation because the entire core is exposed to the formalin. So it's a very good tissue for IHC evaluation. Again, it may be avoided in the suspected lymphomas because many times the lymphoma involvement, especially in the low grade ones, can be partial. In the Hodgkin's, we might not see the Hodgkin cells, or we might have a partial involvement by follicular. So if we are suspecting a lymphoma, then it's better to obtain a whole node biopsy. For all other purposes, a core biopsy is the standard now. Now, whole node excision biopsy or an incision biopsy is the best modality to assess suspected lymphomas or indeterminate nodes on imaging or partial involvement of lymph node. It gives best information. The importance is that it gives a overall architecture, lymph nodal architecture. So subtle changes, any background changes are better visible in the whole node biopsy. And one thing that it should be quickly sent to the lab in formalin, because the lymph nodes are intact. So the formalin takes time to penetrate, and lymph nodes undergo autolysis very fast. So if you send it to the lab fast, we'll bisect it or chop it so that better fixation and further better evaluation can be done. Coming to neck dissection specimen. So in frozen section, we do intraoperative consultations. You all know we send level 1A for to take the decision about the bilateral nodal dissection. We do send SOHDs to determine whether the SOHD, we should stop at SOHD or do a complete neck dissection, modified radical neck dissection. Then we have a role in the sentinel lymph node biopsy evaluation. Selected neck dissection to determine how much level further should we dissect the node. It's usually the norm, I think, to go 2 levels beyond the positive lymph node if we receive in the frozen section. Then again, in the neck context, parathyroids are also sent for frozen section during thyroid tumors. In the final HPR, the lymph node evaluation plays an important role. First of all is the number of lymph nodes. So number of lymph nodes that are dissected, the lymph node yield, it is called. It determines the adequacy of neck dissection, whether the neck dissection has been adequate or not. The criteria currently accepted is of 18 lymph nodes. So if you have 18 lymph nodes, to call it negative, you should have at least 18 lymph nodes in the neck dissection. Then total lymph node burden, number of positive lymph nodes out of the total lymph nodes. the size of the metastasis within the lymph node. So we microscopically measure the size of metastasis in the lymph node. So in the HCC staging system, the size of the lymph node is the size of the metastasis, in fact. Then important thing is the extranodal extension, whether it's present or absent, and what is the extent. So now more than 2 mm away from the lymph nodal capsule is considered as major or a grossly visible extranodal extension, that is called as major extranodal extension. Minor is less than 2 mm outside the capsule. So these are few of the gross appearances of lymph nodes. This is after fixation. You can see translucent, shiny lymph node, sort of a brownish tinge to that. The after fixation, the brownish tinge reduces a bit. And this is the cut surface of an involved lymph node. So it is, as you can see, it has become opaque, whitish, and it feels also firm. The usual lymph nodes are soft in consistency. Now, this is the appearance of the lymphomatous lymph node. You can see an homogeneous, white, firm, fleshy appearance of lymph node. Okay, and the tendency has been described as rubbery also in the Hodgkin lymphomas, especially. Now, these are the lymph nodes. Can you see this whitish friable material? So, this is the cheesy material or the caseous necrosis of a tuberculous lymph node. Coming to brief microscopy pictures. So this is how a reactive lymph node looks. We can see the germinal centers and the lymphoid follicles at the periphery. And this is the near the hilum. Over here, another picture of reactive lymph nodes. Here we can see the dilated sinuses. So these pale areas are in fact the sinuses. Higher power. Now we can see this is a higher power from a metastatic lymph node. So this is where we first detect the metastasis. So this is a subcapsular sinuses. This thick part is the capsule, and below that we have an island of tumor. So during the lymphoid drainage, the metastatic cells first come to the subcapsular sinuses and then spread. And this is the right side image is an example of an extranodal extension. Here we can see the lymph nodal contour, and here the tumor cells are going out of the lymph nodal contour. So we are supposed to measure the outermost extent of the metastatic disease from the usual contour of the capsule. So that is the extranodal. That's how the extranodal extension looks on microscopy. Some pictures for a TB lymph node. So we have a granular necrosis over here, a giant cell, a Langhans type giant cell, and the granulomas. This is a picture of the a lymphoma. As you can see, the lymphoid cells are large and diffusely arranged. So this is a case of diffuse large B-cell lymphoma. So some general points, my last two slides. So what are the usual causes for discrepancy in the clinical or radiology findings and the histologic finding? So there might be a very subtle involvement of lymph node, small subcapsular deposit, which might not be detected on palpation or on radiology. Extranodal extension, sometimes what happens that clinically or radiologically, it's a big mass, 3-4 centimeter mass. But many times the lymph node capsule is still retained in such a big node also. So it's on microscopy, it is ENE negative. Then in cases of post-chemotherapy, there is a lot of fibrosis and hyalinization in the lymph node. So on imaging or palpation, you might feel the lymph node is still firm or not regress that much in size. But on on clinical examination, I mean, on microscopy, when we see just the fibrosis and the residual tumor cells might not be present, or we might see in the squamous carcinomas, we might just see the acellular keratin. So the material might still be there, but it won't be a viable tumor. Then sinus histiocytosis or fatty infiltration can cause enlargement of lymph nodes. So clinically, the lymph nodes will appear enlarged, but they won't be involved. Then there might be combined pathology sometimes. Many times in Hodgkin lymphomas, we see granulomas, coexistent granulomas. In squamous carcinomas, also patient has reduced immunity. So sometimes they can get the granuloma. So we can have a combined pathology. So on imaging, it might appear that it's a granulomatous lymphadenitis, whereas we have a tumor also. So A last slide to tell some of the points in brief. So adequate history and imaging findings, where especially when you are sending the lymph node, any sample of lymph node for unknown primary, because we have to choose an IHC panel. So depending on, we might put organ specific immunohistochemistry. Sometimes we can put general immunohistochemistry. If the tumor is too much poorly differentiated, we might have to put both the lineage markers. If it's a malignant round blue cell tumor, then the immunopanel is very wide. So it helps always if you have, especially PET scan findings, if you have any primary. Incidental findings we find in lymph node, we can see the papillary thyroid carcinoma in lymph nodes dissected for head and neck cancers. Metastasis in upper cervical lymph nodes many times in unknown primary. So we tend to do P16 IHC, which might reveal subtle lesions or just thickening in the oropharynx or the tonsillar lesions, which might not be apparent on clinical or imaging findings. We can go for EBV, LMP, or Iberish on the, especially again in the upper cervical lymph nodes. The nasopharyngeal tumors are many a times not visible on imaging, or they present as a cervical lymph node rather than a primary mass. Metastatic supraclavicular lymph node, again, numerous possibilities. History is very important. You can have all the tumors from lung, GI tract, and even the lower genitourinary tract, even the germ cell tumors. Again, the lymph node yield which we are talking about. So post, especially in the post NSCT and the post CTRT specimens, we have a lot of fibrosis in the neck. So there the lymph node dissection might be difficult, and many times lymph nodes also get regressed. So these were the few points about a pathologist view in the lymph node. So that's all, I think. Thank you.
Very good presented, Ketan. Any questions?
Still your question. When will you allow us to do FNEC in certain nodal diseases rather than the biopsy?
In nodal diseases, sir, when the primary is known, we just want to assess or confirm whether it is metastatic, or in the recurrent setting. So patient has been operated previously, now presents with the mass, where you know that the natural history of the disease, that this is likely to be that tumor, or you want to rule out the benign pathologies you are suspecting. So basically, FNAC can be done in all those cases, except where the primary is not known or the patient is initially being evaluated. So in those cases, the FNAC should be restricted, and lymphomas, suspected lymphomas.
When you say restricted, would it be get some idea? Because when we are seeing a patient presence of lymph nodes, our initial diagnosis will be only with an FNAC.
FNAC.
Because we will first do an imaging, because that's priority. Because even in unknown primary, if I do an open biopsy, I'm going to vitiate the tissue. So by our clinical pathway, we would first do an imaging and then do an FNAC. If you all then point out towards a lymphoma or a metastatic disease, then we would do further investigation. So we may not avoid an FNAC altogether, but we should do an FNAC so that you all tell us that this might implicate a lymphoma. So then we will do further tests. So if it's a lymphoma, then we would go in for a whole node biopsy, sending you the entire node, because the core will not help you. You need the entire node.
In cases of lymphoma, but sir, in cases of unknown primaries, the core biopsy gives very good
So unknown primary is a different thing. If it's pointing towards lymphoma, we would rather do a small node biopsy.
Yes, an incision biopsy.
I think sometimes Madam Chinoy expects me to send both FNEC as well as biopsy.
As well as
what is the reason for that?
So, sir, sometimes we ask usually for biopsy imprints or an FNAC. So, FNAC, the smears give very much nice details about the nuclear morphology. So, certain tumors, the nuclear morphologies are very important. So, PAP staining or the other cytological staining bring out the nuclear morphology nicely in the details. So, especially in the malignant round cell tumors or in lymphomas, we might get some help in that, but it won't lead us to some specific diagnosis, but it will help if a core biopsy is accompanied by FNAC. It will help us in the diagnosis of the core biopsy. So that's how.
Is there any role of immunocytochemistry, or it's not just done?
Yes, sir. Immunocytochemistry, sir, it is done on the smear. So, like from the paraffin block, you can cut 25, 30, 50 slides, but smears are limited 7 to 8.
Right.
And immunocytochemistry, all the immunohistochemical markers don't work very well in the immunocyto smear, the cytological smears. So that's why we might get a bit of background staining, and also it has a very limited role. And the expertise of immunocytochemistry, the technical expertise to do immunocytochemistry is also requires an experience of immunohistochemistry, long-term experience. Immunohistochemistry. So that's how it is. So immunocytochemistry is generally not advised. We just keep it reserved for the ascitic fluid smears, where many a times we don't have the tissue diagnosis, ascitic or pleural fluid, when we don't have the biopsy. So there, if you have to do, then we do it on the, and it's better to do it on cell blocks now.
You had always difficulty when there's a lymph node which is tuberculous.
Right.
When it comes for biopsy, we open. I'll start from here. Okay. Good morning, all of you. This is about talking about the lymph nodes. I think this, I just want to discuss how it all started about the lymph node imaging. Way back in 2000, we bought the first ultrasound machine, which was having color Doppler. And Dr. Pradhan sir once asked me, can you do a sonography of the lymph nodes? We were not aware that there can be metastasis can be detected. So those days, I think we fetched few articles from the library, and then we realized a lot of articles have come from some Indian called Ahuja. Then I realized there's a lot of work has gone into detecting a lymph node, which is going to help surgeon that whether it is a metastatic. So with that background, we started over a period of time, and there was initial days, we picked up one popliteal fossa node in a melanoma case, and we said it's metastatic because it looked like abnormal, and we did FNAC. And this patient went all the way to Memorial Sloan Kettering, and then they presented that case that ultrasound can pick up a lymph node metastasis. So this is a nice kind of feedback we got from the patient. Then we continued taking it more seriously. And I think, but as usual, Pradhan sir was the one who allowed me, who made me do first nodal ultrasound. So I think lymph node is something which we encounter during palpation, which that's why we do the imaging, because it is expected in oncology workup and in the follow. And we do a lot of FNA and biopsies, which becomes your second hand. And the etiologically, we understand that it is mainly the granulomatous in our country, which is TB and sarcoid, mainly the TB. In malignancy, we see a lot of squamous cell carcinomas, differentiated thyroid carcinomas, lymphomas, unknown or remote primary, which could be anything like melanoma. Others are like some Ks are there, like the Kikuchis, Kimuras, Kawasaki, and if you say Castleman with K, maybe it looks like complete kind of mnemonic. And there are some viral and Epstein-Barr virus. And there's a mixed etiology, as Ketan said, there could be a tuberculous and lymphomatous node in the same setting. The nodes, the distribution is such that about 75% occur into the, the neck, and 1%, mainly the axilla and higher up is complete nodal status, and remaining are there distributed in the body. But since the head and neck has about 55%, we take distribution. We talk about node generally. When we talk about node, it is about the head and neck. So we should just be knowing some facts, mainly the radiologist, that there can be a known primary, so it's a little easy. There can be multiple levels, there can be skip levels. In differentiated carcinoma, generally, we don't get level 1 involvement or level 2 involvement at presentation. In lymphomatous and tuberculous, the entire chain can be involved. In unknown primary, mainly the level 2 which gets affected. Contralateral and skip levels are very common in C8 tongue, so our job is not over TBC, the other side. And right supraclavicular and left workup nodes come from subdiaphragmatic pathology, and that can be one of the reasons why we would evaluate the neck for the disease purpose. Distribution wise, I think we all know that a squamous cell carcinoma has particular pathology, a particular focus will come to a typical level. So I think we should be just knowing that there will be a typical distribution, and that's when you will suspect that since the node is here, the pathology may be in certain area. And there are likewise other etiologies also which affect particular group of nodes. So I think that makes our job slightly easy when we anticipate node in that particular area. But we understand that a palpation alone cannot tell if the lesion is a node or other lump. And once we know it is a node, if it is benign or malignant. So palpatory negative NEC will still have about 20% chance of nodal metastasis. On the other hand, the metastatic node reduces 5-year survival rate up to, if it is on one side, up to 50%, and both sides again dramatically goes to 25%. At the same time, patients with T2 or larger lesion may undergo some form of elective NEC treatment, and we get chance to see whether our nodal characterization is correct or not. Accurate lymph node imaging will help us to adapt a wait and watch policy in certain cases, follow-up of identified node, or by adding FNE, avoid morbidity of unnecessary treatment, and it may be a useful tool in a busy center with too much of workload where we can avoid certain dissections. Our aim is to know what is the anatomy, how it looks on pathology, and we try to replicate that on ultrasound. And that is the general consensus by which we can almost make a node look much larger. And that is the one of the advantage compared to CT or MR, where a node is seen very small. So you have to focus quite differently compared to the magnification and spatial resolution which ultrasound allows us to see a node very correctly. So I think this is one of the reasons why we try to replicate something which a pathologist can see. We try to see it under ultrasound. Kidney and node, I think it has been described. We used to see in anatomy books the kidney is bean shaped and bean is kidney shaped. So something similar occurs here. I think a very large node and kidney almost can look similar. And we use this information to our advantage. That means we try to see each node as a single organ, and that is one of the reasons why ultrasound slightly scores for, provided you see particular node carefully. So if I were to just give you some non-specific description about the kidney, which has calculus, SOL, abscesses, is a perirenal spread, there can be angiomyolipomas and cysts. Something similar, in my opinion, occurs in the lymph node, which can be calcification, can be focal inclusion, there can be focal necrosis or infection like tuberculosis, or even SCC metastasis. There is a perinodal spread, focal fat, and cystic change. So this all really helps us studying each node as a kidney, and then you tend to score over other modalities. I think just surface markings, I'm not going to discuss to the surgeons because I think there's one talk ahead on the nodal levels by Karnav in future series. So I'll just say generally we try to understand which triangle it is. And there are 3 muscles and 2 cartilages which help us, the digastric, omohyoid, and sternocleidomastoid. They form multiple triangles, and hyoid and cricoid are the areas by which we divide the various levels. I think we would not go into the details about the level, but we should generally know where that node is situated so the surgeon gets helped and we don't have confusing term between radiologists and surgeons. In addition to all the 6 levels which we are generally encountering, the 7th level is something which is a mediastinal level, and some descriptions say 7th level is also the retropharyngeal node, which we generally don't see on ultrasound. This particular 7th level, the mediastinal node, can be seen by some of the spatial ultrasound probes. So we generally do know that these nodes exist there. And level 3 omohyoid is the level 3 for the supraomohyoid and infrahyoid dissections. So we should be just knowing where that muscle lies. Central lateral compartment is what radiologists generally can get sometimes confused. So simply between the 2 carotid sheaths along the thyroid and the trachea, whatever nodes come, those are the central compartment, barring 1A, that is the submental nodes. I think this distinction is also important for us, so that a node which occurs at the level 3 almost will be occurring at the level of level 5B node, and we have to label it such so that you don't cause confusion while surgical team is dissecting them, and they we would not like them to come and say that you gave the wrong nodal level. I think amongst all the nodes in the levels, I think we understand only the retropharyngeal and some of the deep-seated retrostyloid nodes are not seen in ultrasound, but they are considered as level 2 nodes. Rest of the nodes, I think we all tend to see. Central compartment is something which we tend to carefully see in esophagus and thyroid. Otherwise, the rest of the areas are mainly focused for squamous cell carcinomas. Retropharyngeal nodes are only seen on CT and MR, so we should, as a radiologist, we should know that these nodes can be missed on ultrasound, which can cause staging problems. So I think we should be aware that if there's extensive disease, I would rather study the cross-sectional imaging that I am not missing any node there, which becomes an important aspect. And as I discussed earlier, this is the node which is the mediastinal node, but small footprint, the intracavitary probe can give us good wide view by which we can pick up this node. This was a papillary cancer node in which we could tell sir that the node is here and they could dissect it out very easily. What are the criteria for lymph node evaluation? I think the main criteria are size, shape, central hilum, echo texture, margins, and color flow. And we use all this in combination. But in addition, there are different clues, that is necrosis, matting, interval change when we follow up a node, and PET CT clues which allow us to look at a particular node as a second look ultrasound. So I think we'll just go by certain features and we'll try and understand. These are the line diagrams, how a normal node would look like and how abnormal node will start looking much larger. We generally take size for documentation purpose. But in addition to that, in a nodal staging, knowing the exact nodal size will allow us to know which TNM staging it is going to be finally representing. A node which looks such large and abnormal really does not need to be understood, specified by us, because it really looks abnormal. And these are nodes which I'm sure the clinicians would really feel and they say this is definitely abnormal. But the shape is something which sometimes causes confusion. By and large, a node which is oval, which is considered as wider than, which is considered as rounded node. When it becomes a taller node, it will start changing its shape, and that is when we tend to understand that the node may be becoming abnormal. But there are exceptions to this rule, because some of the supraclavicular and submental nodes, to begin with, even though they are normal, they may be still rounded. And when we see these two pictures side by side, that's the typical lymph node, which has a cortex, and this is the hilum. And as against this node, it shows loss of hilum, and it is looking much larger just in the vicinity. So naturally, this shape is abnormal. The size has grown up. So we will say this is an abnormal lymph node. Coming to this other criteria about the maximum to transverse ratio, is important point is in cross-sectional imaging, you tend to see the transverse dimension, which if it is more than 9 to 10 millimeter, it is considered, given a second look, whether that node is abnormal. But in ultrasound, we do take both the things, the maximum to transverse ratio, and as the node is oval, it is likely to be normal, but as it starts becoming abnormal, it will be getting more and more rounded. So the ratio will alter automatically and it will become less. So I think that is how we would look at that ratio. Hilar fat displacement, as we understand from here, is something which a node will have a fatty white looking hilum through which a vessel runs through, but that can get displaced because there's a tumor deposition in that area, and which is what generally allows us to pick up an abnormal node. So this is a normal thin hilum which may not be seen. So erroneously, some reports outside write that the hilum is lost, but actually it may be seen by the side and you don't tend to see it. And if not hilum, sometimes you see the hilar vascularity and you know the hilar is present there in the normal position. Sometimes there's a focal cortical bulge which will allow hilars to get displaced, and this is the sign by which we tend to say this is an indeterminate node and tend to do the FNAC of such nodes. Subcapsular vascularity, I think this is an important point. Normal hilar vascularity is a radial shape, but as the neoangiogenesis occurs, the vascularity will come from the capsular side. And this is one such example where you can see the vessels coming from periphery, and this certainly shows that there is a tumor infiltration. So against this normal radiating hilar vascularity, when you tend to pick up this vascularity, you will certainly give a valid explanation that this is a metastatic node. There are patterns by which you can decide whether a particular node is going to have a single vessel or branching vessel depending on the sensitivity of your machine. But we should know that node with multiple branches, these are common in acute lymphadenitis or lymphoma, and displacement occurs whenever there is an inclusion, and subcapsular vascularity occurs when there is a neoangiogenesis. As against, there's a necrosis can be seen as a focal lack of vessels. So I think we should just know just couple of examples. Inclusion can cause vascular displacement, new vessels coming in here, and a very disorganized node with a lot of abnormal vascularity. And this is where we'll say this is abnormal. Some of the metastases like a papillary and medullary cancers and lymphomas tend to inherently have a lot of vascularity, and only the vascularity tends to allow you to say this is an abnormal node. You can see the totally disorganized vascularity in a small looking flat oval node, which would be otherwise passed as normal. But this vascularity makes you understand that this is a certainly abnormal node. And that's the important clue. I think we discussed this acute lymphadenitis. It looks really tense vascularity there, but it still maintains its normal pattern. Then we tend to understand that it could be acute lymphadenitis. And very important point about this is very often when the biopsy is done, we tend to see such a node which is large and shows a lot of flow, and we may erroneously call them abnormal. So this is our important point that we ask the patient when was the biopsy done. Now, focal cortical bulge, we discussed this when the hilus and the cortex is symmetrical around the hilus. That's normal. When it becomes one side is becoming abnormal, especially in cases of CA brace, we tend to see this as an abnormal thing. And this is when we pick up a node being abnormal. And we tend to do FNA. If we are to be done, it should be done from this focal cortical bulge, which allows us diagnosis here. Cystic change, I think, as we understand, very common in SCC and PTC nodes, where we tend to see typical necrotic areas. And this is a sure shot sign of a very abnormal node. The only problem is sometimes in tuberculosis, we do see such changes. So I think FNA can be done if it is not known primary. So this is a node on various machine. It may look normal, but on other machine, on a better machine, it starts suddenly showing necrosis. One such tool to pick up necrosis is the elastography. So we tend to add that. On elastography, when we see a bullseye sign, that means there is red, blue, green. In the center, there is red, which is softer. Then we tend to know that this node, particular node, the elastogram shows this sign. So it is an abnormal node, and we understand it is a cystic node. Intranodal coagulation and cystic necrosis. I think there is coagulation necrosis is generally echogenic, and cystic necrosis is echo poor, and that is common in papillary cancer and late SCC, while coagulation necrosis is common in TB, which can be echogenic, and metastatic inclusion from squamous cell carcinoma. So I think the next point is the microcalcification, which is very important for detecting differentiated thyroid carcinomas like papillary cancers, where we tend to see psammoma, punctate, and papillary. All these three P's go together, and that is how it shines like a calcification of foci, like a microcalcification in breast cancer. I think we tend to understand that. So these are some of the varieties where we see those punctate calcification, and we say that this node, even though it looks small, looks oval, has a hilum, but still those calcific foci will make you aware that this is an abnormal node. In fact, it can be the only clue on CT scan that only calcium is seen. Here we can see that there is a node which is seen anterior to jugular, very small node, but it was a metastatic node picked up because of the calcification. Extracapsular spread, I think there is always some kind of problem on imaging, but in combination, most of the imaging can give this clue. CT, because we tend to push a lot of contrast, so necrosis stands out, the margins are seen better. Unlike that, on ultrasound in transverse section, you'll see that a part of the node has lost its outline and is merging with the adjacent soft tissues. And I think whenever we tend to see this, we have studied in our own setup that when we pick up extracapsular spread on sonography, because the node is lost its outline, we tend to be generally right, and that's when we try to look at more carefully. You'll see some vessels coming from periphery, and the node would have become disorganized, even though it may be a small node. So we generally tend to do transverse section as well as longitudinal, so we can pick up this extracapsular spread better. Margins, I think we understand one simple point is unsharp borders are common in tuberculous node because of the periadenitis, and metastatic and lymphomatous node tend to have sharp border due to tumor infiltration and reduced fatty deposition. So I think this is one important clue for us. Last but not the least, this is the focal cortical bulge, which we tend to pick up in a otherwise looking normal node, which has a good hilum here. Only this bulge will stand out, and this is the earliest focus, which could be labeled initially as a micrometastasis. So we tend to look out for such small deposits, and they really help. And not much has been described about this in literature, but we have found this is a very valuable tool. So this was a young doctor, and she has had normal looking node here. If you see this node, it looks fairly oval, it has good hilum. Only these two inclusions, which are hardly 3 millimeter or so, this was the metastatic deposit. When we did the FNEC, it was on the opposite side, and this really helps. So I think picking up these clues are very important, and we tend to do that quite often here. Sometimes these multiple inclusion can look like this bizarre, and they are all metastatic deposit they form. Now the larger group of multiple inclusion can make that node look abnormal. So this is a typical one, nodular, inclusion, which could look like a angiomyolipoma in the kidney, and this is how we tend to look for these particular inclusion, which allows us to pick up early diagnosis. What are the diagnostic pitfalls? Large fatty hilus can, on imaging, can look like inclusions. We have to be aware that whether this is fat or whether this is an inclusion, I think that comes by seeing the echogenicity, and we generally not make any mistake. And sometimes the inclusion looks like a necrosis and then starts disintegrating over a period of time. We just skip. These are the generally, inclusion is not often mentioned feature in literature, but the frequency of metastasis was, seen into 62 to 100% of patients with absent hilum, about 19 to 80% in those round shape, and up to 86% with hyperechogenic nodes, and up to 50% with calcification, depending on what type of calcification we see, and up to 70% with cystic change, and about equally 50% or so in abnormal vascularity. But the problem here is the range is so wide that we can't really go and give that importance to that one particular point. So we see a node with additional clues, like in papillary cancer, we tend to see a very large cystic node, which almost looks like lymphangioma. So the clue is something which is solid within, and if it has a vascularity, or a node which has solid nodule plus debris, which is due to a frank necrosis, and these are definite signs of malignancy in those cases. So we'll go back. The only differential for such a large node at level 2 would be a branchial cleft cyst, which can have similar squames on the cytology. So we should be knowing that the node which has a large, thick ring of tissue here is different than a complete ground glass cystic lesion. So this is one of the mimic of a node. We tend to aspirate node during FNEC, and I think so much so that they're so necrotic, the entire node vanishes. So probably during those times, they may just disappear from visualization, and you would probably see only as a flat node during dissection. So what makes node diagnostic for metastasis? I think from all this discussion, we've understood these are the combination of all the features which we discussed so far. So most of the signs are interconnected. I think we'll just skip. This is how we document the nodes, and we take a little bit of just 2 slides for understanding tuberculosis. I'll just skip there. So one additional point is we in our institute tend to follow up node over a period of time. So node which looked kind of flat, normal, in few months time or few years time, if it starts looking different, then naturally this becomes a reliable and definite sign of metastasis. So that's why we tend to keep our old images and document. Reverse can happen. A post-treatment like RT has been given and this node has become now much smaller and it starts looking a normal node from a much larger abnormal node. So this is also a clue. I think we'll skip. And in tuberculosis, just one additional point besides knowing a node can be tuberculous is little difficult. Sometimes we understand, we tend to see a node which has got a bizarre shape or it still has little lobulated shape. But under the node, we tend to see some increased echogenicity below the capsule, and that is considered as one of the sign of tuberculosis, that the early necrosis has started from the periphery, and this really helps us to pick up this could be a node, but the final answer would be in the needle. I think there is one additional point that the tuberculous calcification and psammoma calcification, there will be a little bit of distinction that the tuberculous calcification tends to be much coarser compared to the psammoma, which is very thin, and that's when we say. But as we discussed earlier, there can be coexistence of both. I think with this lymphoma in general has a very peculiar appearance because it's a very cellular node. It has a typical micronodular or reticular appearance, and there can be some additional big vessels, and that's when we tend to pick them as a lymphomatous node. And it generally has an intense vascularity, and you can see that kind of vascularity is seen in the proven. This is a proven lymphomatous node. So I think this is one other differential which we tend to really highlight. A node which was diagnosed earlier, we asked for biopsy. He didn't want biopsy. In about a year's time, he's come back and the node has become larger, and this was a lymphomatous node. So I think this was additional point clue. Supraclavicular nodes, we generally do as a substitute biopsy for the infraclavicular pathologist. So we always on the lookout for this so we can avoid some lung biopsies. I think with this, I think we should just know some of these structures which can look like node, and they are thrombosed veins, sometimes foreign body granulomas, postoperative granulomas, Warthin's tumor, and neurogenic tumor can look like. This is a very common thing after the nodal dissection, especially the tongue lesions. You tend to get a very large submandibular gland, which is hard, but then we understand that this is a submandibular gland and not the node. And a thrombosed vein or granuloma can look like a node, so which is one of the mimics. I think I'll skip this. The schwannoma can definitely look like node, but the vascular pattern is very bizarre. And in such scenario, this is a papillary cancer with large metastatic burden. I think the ultrasound would not be sufficient because the nodes are going to go in all various levels, including the mediastinum. And when we need cross-sectional imaging, this was one node which was considered as node outside, but when we realized this is a tumor thrombus and not the node, so papillary cancer or thyroid follicular cancer can tend to overflow into the jugular vein and cause the abnormality. That's the general accuracy of nodal detection. So ultrasound and FNAC combined, the accuracy goes up compared to other modalities. But as other modalities are using newer contrast and better sequences, this accuracy and specificity would go up. But in general, ultrasound alone and ultrasound with FNAC, the accuracy would be much superior compared to other things. What are the disadvantages? It can be a little bit difficult, operator dependent, and false negative can be due to sampling the wrong part of the correct node, overlooking small bulges in small necrotic area. And we understand CTM or ultrasound more accurate than the palpation, but not high enough to justify the change in policy. And we can miss some micrometastasis. So to conclude, we will think the ultrasound of lymph node will diagnose specific abnormality. And very importantly, it will exclude most of the certain abnormalities. And you can say this is not lymphomatous, this is not metastatic, this is not papillary. So it could be something else, like Hncii and all can sometimes cause confusion. It helps us in guided procedures, an excellent tool for follow-up, and can zero down and lead to particular direction. So that's important. So with that, I think I thank everyone for kind attention. If there are any questions, I would answer them. Thank you.
Thank you, sir. That was very lucid. Any questions?
Metastatic nodes would all look the same. I'm looking at breast and even like whatever you mentioned about the sign.
Oh, I think that's what I think. This we talk a little bit more towards the head and neck, but in breast there will be slight difference because in breast we one of the important things is the nodes do not have necrosis or typical change the way we see in the neck. So I think in breast, that's why I said specifically the cortical bulge is what we really look at. So if there's focal cortical thickness in one particular corner more than 3 millimeters, so we will call them abnormal. So that is the difference.
So there's always a concern for lymph nodes in the neck. And,
Right.
Even in our study from Pathologist, we saw that the yield of an ultrasound is less than compared to CT scan.
Right.
But all the data that we read in literature and in Rectal's papers,
Right.
that the ultrasound yield is much better in the European data. But in our own CT, yield was poor.
Okay.
So why is there a discrepancy?
I think it depends on the way you've been using it for over a period of time. So I think what has happened, in fact, ultrasound would be an excellent second look tool even after question mark CT or MR findings. In fact, we find that very important that a lot of patients come to us with, say, so-called abnormal node or normal node on CT and MR, and it would be exactly reverse on ultrasound. It is proven so. So I think if you use ultrasound as a correct tool for that particular node, ultrasound gets bad name because you don't see that node in the first place. Suppose it's posterior higher up level 5A node, you tend to kind of miss that node because patient has not been turned around so much, or there's a node which is just below at level 4A or supraclavicular. Those nodes are missed. So I think that's why we get yield would be less. But if you use it correctly and document each level. So we also nowadays, in fact, we are trying to think that even if anybody does ultrasound in our department, they should show those many pictures in 2 planes compulsorily, then we don't miss those nodes. I think that's the only reason. Otherwise, picking up a node and seeing it on a high resolution ultrasound, the image quality would be far superior than anything else.
Is it because now you have better quality photos compared to the past?
Yeah, but that has also helped the MR and CT also. The imaging has become much better, faster. So the necrosis is picked up on contrast ultrasound, even on CT. So in fact, in my personal opinion, because we've been picking so many abnormal nodes, our CT report has improved. It's the reverse has happened in our scenario. So those who used to help me picking up the, reporting CT, they would say this is little big node, size is large, so it is abnormal. But then over a period of time, since they started seeing ultrasound and combining them, I think their yield has improved that they're picking up smaller necrosis better. The advantage of CT would be in the extracapsular spread when you want to see the jugular adherence or carotid encasement, which sometimes becomes a little difficult. So that is the plus point. And I have no personal experience on the MR, but MR with contrast or diffusion weighted imaging, they can pick up nodes slightly better. But again, the point is, as I kept on saying, to treat one node as one organ and you do justice to that.
And what is the yield? Meaning when you said that you had this inclusions or yield within the node, what size should they be for us to actually be able to identify and?
So I think we are seeing 2 to 3 millimeter inclusions. And in certain cases, the node looks absolutely flat. I'm sure it would not be palpable node. And that inclusion just stands out because of the difference in echogenicity. So that is the most important point, that we picked up more nodes. And we have done a lot of, these are not the published studies, but whenever we used to get dissection done by you people, and then we used to see all the nodes, which node looked abnormal. Sometimes some dissections do not mention each level separately, but when it is mentioned, we tend to understand that we picked up the correct node. So I think suppose we gave 2 nodes positive on nodal ultrasound, and you also got 2 nodes, then we find that is very kind of encouraging. Though important thing is, I think when we say 28 nodes dissected, we don't, I think, necessarily see them. So that is the one of the important points. As a radiologist, I would remember that I may not be able to see all the nodes.
Is there I'm sure there will be a concept of, like TIRADS or PIRADS in the determination of lymph nodes. And is it like
There is
useful system?
no thing has been devised for nodes as such for existing nodes, because this is just more of multiple parameters put together, and then we tend to see. And some of the nodes look frankly metastatic. There is no problem in those. Those which are borderline, we can have problem. So in fact, we tend to use that indeterminate word a little more commonly than anyone would like. We want to reduce that percentage by saying we would be doing FNAC. So the advantage why we started doing better is because we were allowed to do more FNACs in initial period. So we used to be very happy that we would pick up an abnormal node, not by ultrasound, but by FNA, and then we tend to kind of learn from that period.
So now we are now shifted to doing a prophylactic neck dissection.
Right.
So has your practice changed over time?
I think our value has little bit, we have got, we also have become little complacent in certain sense that anyway they were doing dissection. So we are not asking for FNAC as frequently as we were asking. And they also do not want us to do FNAC because they're saying anyway we are removing node. So then only our job is to understand from the specimen and the histopathology what we did correctly or not. So that is the difference. So the FNAC rate has gone down over a period of time because elective dissection is quite common. But in those cases, I think we are probably helping them for the opposite side.
I think the most important thing would be the contralateral because
Yes.
we tend to miss it when we do an ipsilateral neck.
Yeah.
So the yield is about 4 to 5% in the central node biopsy. So maybe we need to focus on the contralateral neck nodes.
And for
And the
radiology,
abnormal sites, parapharyngeal space, the retropharynx.
yeah.
Those are the areas which we will never take.
Yeah. So I
never
think,
decide.
so I think retropharyngeal is something is what ultrasound can't see. So we will go back to CT, carefully see it. But in general, if I were to see, would you agree that retropharyngeal nodes are uncommon? So that's why ultrasound is somehow sails through.
We tend to get these recurrences or residuals only in these areas because in a routine neck dissection, we will not go and dissect this.
And in nodal biopsy for radiologists understanding, we generally should take first sample into the saline. So we would always retain that for tuberculosis if required. And sometimes we overdo that, but it helps in certain cases. And then next subsequent sample we take in formalin.
Hello, Asif.
Yes, sir. Good morning, sir.
Good. Asif, excellent talk. Really excellent talk. I want to ask you about these retropharyngeal nodes. I
Yes,
believe
sir.
you're doing the oral ultrasounds now.
Yes, sir. That is used.
Aditi was telling me.
It's a intracavitary.
Can you also do hypopharyngeal ultrasound and see these retropharyngeal nodes? Because sometimes we find the neck disease is resectable. And you find, oh my God, the MR imaging says that there is a retropharyngeal node. And sometimes on the contralateral side. And you keep feeling that, should I just do surgery on him or should I send him away for chemo radiation? Will an ultrasound throw more light on that if you have a hypopharyngeal ultrasound? You think you have that?
No, we can use the intracavitary probe with topical anesthesia, and then to avoid gag, then we can use it. It is used also for the higher carotid bifurcations in general. So the same principle can be used. Something similar is used for the seeing area behind the tonsil. So I think a probe which has been inserted, only thing is a little cumbersome for the patient, and you have to use it with some topical anesthesia. So I think that's the only problem. The other method by which we use, I can, get somewhat similar result is by using the same small footprint probe, putting behind the mandibular ramus and then looking upwards. And we have picked up some nodes by seeing from the skin side only, not orally.
What an excellent talk. What an excellent talk. Thank you very much. Thank you.
Thank you, sir.
I must thank Prathamesh and Karthik also to organize this very beautifully. Really, they need to be congratulated for this. Thank you very much.
Thank you, sir.
Thank you, sir.